Hello, and welcome to the Thyroid Pharmacist Healing Conversations podcast. I'm your host, Dr. Izabella Wentz, the thyroid pharmacist. And today we're going to be diving into T4 and T3 combination therapy, as well as natural desiccated thyroid with Dr. Brittany Henderson. Brittany Henderson is a board certified in internal medicine and endocrinology with advanced training in thyroid disorders, including Hashimoto's thyroiditis, Graves' disease, thyroid nodules, and thyroid cancer. Originally from Ohio, she graduated near the top of her class at Northeastern Ohio Medical University, where she received the honor of Alpha Omega Alpha. She completed her endocrinology fellowship training under a National Institutes of Health research training grant at Duke University Medical Center. She then served as medical director for the Thyroid and Endocrine Tumor Board at Duke University Medical Center and as the clinical director for the Thyroid and Endocrine Neoplasia Clinic at Wake Forest University Baptist Medical Center. She also has served as the president of the American College of Thyroidology, has received multiple prestigious grants from the American Thyroid Association and the Thyroid Cancer Survivors Association as well. Her work has been featured on the cover of Thyroid and in many other scientific journals, including Endocrinology, Gut, and OncoTarget. She hopes to improve the quality of life of those living with thyroid disease, both through novel research and medical guidance. For people living with Hashimoto's, she believes that knowledge is power. She has a clinical practice that's dedicated to patients with thyroid disease, specializing in autoimmune thyroid disease, thyroid nodules, thyroid cancer, ethanol ablation, and advanced minimally invasive techniques. In addition to using a mainstream medical approach, Dr. Henderson also uses complementary medicine to explore underlying root causes of thyroid disease. So, Dr. Henderson, thank you so much for the work that you do for thyroid patients, and thank you so much for joining us today.
Thank you for the invitation. I'm very excited to talk through this and, maybe give some endocrinologists not as bad of a rap.
Yeah, I really, really appreciate you because I feel like a lot of endocrinologists, I mean, going to pharmacy school, I learned about levothyroxine, and that was kind of the be all end all to thyroid treatment, right? It was like if somebody has an underactive thyroid, levothyroxine is where it's at. You do not need to think about natural desiccated thyroid. Sure, if somebody's been on it for a while, you can, refill their prescription or keep them stable and so on and so forth. And it wasn't until I was diagnosed myself with Hashimoto's where I really started to appreciate that just because a medication might look good on paper doesn't always mean it's going to work as well in the human body. So I really do appreciate that you have been, you've gone through the conventional training as an endocrinologist and you've kept an open mind to really appreciate what are some of the things that are working for your patients.
Yeah, I have the same kind of story. I mean, I started in conventional medicine. I'm an MD. We all learn that all you do is you check a TSH and then you get on levothyroxine or T4. That's the standard of care. That's what should be prescribed. You don't prescribe anything besides that. And that's what we're all taught. So, when people come in and they ask me, like, why doesn't my endocrinologist know these things? Why don't they check a full thyroid panel? Why don't they consider other formulations of thyroid medicine besides just T4? It's because we just learned that. We don't learn the other stuff. So yeah, coming from that world and then ending up in a world where we use all different forms of thyroid medicine, including T4, T3 combination, and NDT, is very interesting. It's been a journey, for me, because I came out of fellowship and I was like, doing thyroid research, and I was running the thyroid program at some major institutions and universities. And I realized in my clinic that I really wasn't helping my patients. My patients weren't getting better. And there's no way that every patient with a thyroid condition on T4 all there's no way that they all have like depression. That it has to be the thyroid medicine, right? So I started listening to patients. I think that's the biggest like learning thing that I've had as being a physician and treating people, is to listen to people, because when I started listening, then I started like opening my mind and actually checking a full thyroid panel, and okay, well, this doesn't make sense. Why is the T3 so low? Obviously, they need combination treatment. And why is reverse T3 so high? Obviously, they're not metabolizing the medicine correctly. And so just really started to explore that. And now, 15 years later, my practice has completely changed. So thank you for inviting me on the show.
It's my pleasure to have you. I, you know, it takes a lot of courage to kind of go against the grain and to go against your training. And I feel like at first it can feel quite uncomfortable and you realize like, hey, I learned about this and I thought like, I took my exams, I took my boards, and I spent so much time on this. Learning this was the way, but it's actually not quite what I thought it was. I'm curious how you kind of overcame that barrier and how were you able to, I guess, learn more about some of the things that, I didn't learn in pharmacy school and you didn't learn in medical school.
Yeah, no. And honestly, like you're right. Like there's a lot of shaming of other physicians, like by other physicians or other endocrinologists, like, oh my gosh, I'm a terrible human because I'm giving somebody liothyronine or I'm giving them an NDT product. And it's weird. It's very much ingrained in medical training that that's not okay. But I went into medicine. Honestly, I went into medicine to help people. That is true. And that's why I started listening to patients because I wasn't trying to just be somebody who could do a checklist and check off the guidelines. I wanted to see people get better, and I wasn't doing that with T4 only. So by listening to patients, reading your book, back in the day, which has been awesome, and then looking at a full thyroid panel, I realized that okay, obviously if I'm an endocrinologist and I was told to give just T4 and I'm only looking at a TSH, and T4 is really good at normalizing a TSH, it's always going to normalize a TSH, then I'm going to think I'm a success by doing that. But if you start to look at the full panel, you realize that that therapy is not good for everybody. That therapy does not get metabolized correctly by the human body because it's an artificial medication. It's not true a thyroid endocrine organ. It does not work the same. So you can see that when you look at the metabolites, when you look at the T4, when you look at the T3, when you look at the reverse, when you look at the antibodies. My understanding grew as I started to understand how the antibodies have a huge effect on patients' symptoms and metabolism. And we use like thyroid ultrasound on all of our patients as well. That has a huge impact on how damaged the thyroid is. There's so many people with Hashimoto's that have never had a thyroid ultrasound, but it's so important. It's like if a cardiologist didn't have a stethoscope. I mean, you're looking at how much damage there is, if there's any thyroid left. Sometimes, after 20 years of Hashimoto's, there's nothing left. The immune system has completely killed the thyroid, and I see that. Or you can look and it can be completely normal looking. And so that person can come off their thyroid medicine. They don't need thyroid medication. And looking at blood flow and other things. So, it's a very logical disease. Everything makes sense with Hashimoto's and hypothyroidism, but a lot of the endocrinologists that are trained in conventional medicine just do not get the training on how to look at the like T4, T3 reverse, like all of the hormones that you need to look at when you're trying to get somebody's medicine correct.
Thank you so much for sharing that. Could we do a little bit of a primer for people listening? Perhaps they're not familiar with the different type of thyroid hormones that are produced by the thyroid gland, and they might not be familiar with all the available medications out there. Could you give us a little bit of a breakdown on that? Like, what is it? What do we mean when we say T4 and T3?
Yeah, that's a good one. So, okay, so TSH. So, TSH is what we all learned to check, and that's what everybody checks, plus or minus a T4. So, TSH is not a thyroid hormone, it's a pituitary hormone in your brain. So, it tells us, is your thyroid making enough thyroid hormone? Is your thyroid medicine strong enough? And so, basically, when the thyroid medicine is strong enough, the TSH is like 1 to 2. If it's not strong enough, the TSH will go high in order to tell the thyroid, hey, buddy, you're not working good enough. You need to work harder. So TSH will rise. T4 is primarily what the thyroid itself produces. So 80% of what the thyroid produces is T4. And T4 is what levothyroxine is and what some of these other medicines, there's Synthroid, there's Levoxyl, there's Tirosint, there's a lot of different kinds of T4. And so, T4 is primarily what the thyroid produces, but the thyroid also produces T3. T3 is active thyroid hormone. T4 is inactive thyroid hormone. So, T4, when the thyroid spits it out, basically is taken up by muscle tissue, liver, kidney, and it's converted to T3 or active thyroid hormone, depending on if the organ in question needs T3. Like if you ran a marathon, your muscles need more of that. So it will take up more T4 and use it and make more T3. Or if like something's injured, like if you get hurt or something, the body will stop that conversion process to allow for healing to occur naturally. So there's a lot to what we call peripheral thyroid hormone metabolism, which is not just T4, T3 spit out by the thyroid, it's how the body takes that T4 or T3 and uses it to make it into active thyroid hormone. And that there's a lot of variables for why that is stopped or why that doesn't occur normally. Even people without thyroid disease, that can get messed up, the peripheral conversion part of it. But that's what I'm talking about when I say T4 or T3 medicine. And T3, there's liothyronine, there's cytomel, there's lots of different, synthetic T3 derivatives. And then NDT stands for natural desiccated thyroid. And that's basically thyroid tissue that is extracted from bovine sources, cow sources, porcine or pig sources, sheep sources, and it's basically thyroid taken from the animal and it's homogenized or made into like a powder and then made into pills. And there are different forms of NDT available, both FDA regulated and ones that you can just buy online as well.
Thank you so much for sharing that. And I think a lot of times people don't realize this is that when you don't convert the T4 to T3 properly within your body, and there could be reasons like genetic variations, or you don't have enough of this nutrient, or maybe you're just too stressed, right? You can have all of these residual symptoms. Like, for example, you can be quote unquote optimized on your thyroid meds like levothyroxine, but you're still going to have the brain fog, you're still going to have hair loss, you still might have excess weight that you carry, you still might struggle with depression. And a lot of times, unfortunately, what I've seen is patients will go back to their endocrinologist and they'll say, "Hey, I'm on thyroid meds, but I'm still having these thyroid symptoms." And then the endos will check their TSH and they'll say, "Well, this is fine and you're already on the medication. So maybe I could refer you to a psychiatrist for your depression, or
Psychiatrist, yes.
yeah, or somebody for this, or maybe you need to see a dietitian for your weight." I'm not against psychiatrists, I'm not against dietitians, but a lot of it is like sometimes these problems can be solved by just getting on the right type of thyroid hormone for that person.
And like I said, like endocrinologists and people that just use T4, T4 is really good at normalizing TSH. So, like, if that's all you're looking at, you're going to think you're doing a great job and it must not be the T4 medicine. Now, like a lot of animal studies and human studies have come out to show that people who are on T4 only, the TSH is normal because the pituitary is so good at like seeing thyroid hormone. So it's very efficient at normalizing TSH. But in the rest of the tissues and in muscle and in liver and kidney, there's low T3 issues. So everybody who's on T4 only has a lower T3 than a normal person. So that's a problem because that not only causes symptoms like depression and weight gain and metabolism issues, but it also contributes to cardiometabolic problems like, obesity, fatty liver disease, cardiovascular disease, all of the things that people get really sick with. So it has to be right. And the first step is having people check a full panel of thyroid hormones.
Did we talk about what a full panel might look like?
We did not, but let me tell you. So it's TSH, obviously. TSH people has gotten a bad rap that it's useless and who cares about the TSH, but it's important too. Not everybody's TSH or pituitary responds appropriately. So sometimes TSH is low, and it happens more in older people whose pituitary is very sensitive. But TSH is important. I check a free T4, which is your inactive thyroid hormone. I check a free T3, which is your active thyroid hormone, a reverse T3. And then for Hashimoto's or Graves patients, we check all of the antibodies, TPO antibodies, thyroid globulin antibodies, TSI, TRAbs, because you can have like kind of a whole spectrum of antibodies. And there are antibodies that people make that we can't even measure. Like if you go to a lab and you get it and you're negative, it doesn't necessarily mean you don't have the antibody. It just means that the lab cannot measure the antibody that your body is making. So it's very much an individual kind of thing, but looking at the full panel really does help you understand how the body's metabolizing thyroid hormone. And looking at antibodies is important too, because even if you're on thyroid medicine and you're on a T4, T3, and you're really working hard to get that right, if the thyroid antibodies are causing the thyroid to do crazy stuff in the background, that also contributes to symptoms. That also messes up the labs too. So you really have to know the full picture to understand what's going on.
Thank you so much for sharing about thyroid antibodies as well, because I feel like some um, clinicians they say like the antibodies don't really matter, but when you look at the research, they've been correlated to so many different issues. Like just having, let's just say your thyroid function was perfect, but you have thyroid antibodies. That itself can lead to a whole host of symptoms that could lead to miscarriage, cardiovascular events that could lead to depression and brain symptoms.
Very commonly, yes. And I always tell people, like, if they have a strong family history of this, Hashimoto's, like, start screening your kids early, like when they hit 10 or even younger, because it takes like 5 to 7 to 10 years for the thyroid to actually start showing abnormalities on thyroid function tests. And that's 5 or 10 years of the immune system attacking a thyroid. And that causes anxiety, depression, weight changes, mood changes, altered neurotransmitters, altered fertility, altered female hormones, because all of this affects all other hormones. So it's really important if you find it early to then make the lifestyle changes that you do so well with, figuring out the root cause of what's messing the immune system up, fixing that so that you don't lose thyroid tissue and you don't have to go on thyroid medicine lifelong. If I'm seeing somebody who's had Hashimoto's for 20 years, the immune system's already attacked and it's hard to get a person off of thyroid medicine. Sometimes they don't even have thyroid tissue when I look by ultrasound. And then you're on lifelong thyroid replacement medicine. So finding it early is really key to getting off medications and preventing having to go on lifelong medicine.
I'm a big advocate of testing those antibodies because, like you said, it can be 10 years before the change in the thyroid function, the thyroid hormones is found. And, I'm always like, okay, if somebody has a moody teenager, it's like, let's think about whether that could be thyroid antibodies. If somebody's a woman in her 20s and she's having irritable bowel syndrome or fertility challenges, it's like, okay, let's think about thyroid antibodies because most women, like you said, they're diagnosed in their 40s, sometimes 50s, and that autoimmune process has been going for 20 years. And of course, we would love to say, like, nobody ever needs medications, but that's simply not the case. Like, some of us just really do need thyroid hormones when our thyroid gland has been under destruction for so long. And myself included, by the time my thyroid condition was discovered, I already had enough thyroid gland damage where it wasn't, there was no amount of gluten free diet and lifestyle changes that would bring back something that was no longer alive, right?
That's true. Yeah, and honestly too, like if you find it early, kids have an awesome immune system. They have progenitor cells. They can like regenerate thyroid tissue, and I've seen that in kids. And the thyroid doesn't regenerate very often. Like it's not like liver. It's like every 20 years or something, like 5 times in your life. But it doesn't really regenerate in as you age. It's more so when you're younger that you would have a chance of it actually repairing itself. So finding it early and not waiting forever is so important. And I wish more providers would check antibodies, especially with people who have a strong family history of this.
Yeah, absolutely. Um, Thank you so much for sharing that. And we had talked a little bit about I guess, some of the biases in the endocrine community. And could we share a little bit, maybe like some historical information? I feel like some of the people that are coming to me, they're like, why doesn't my endocrinologist want to test reverse T3? Why do they not want to give me natural desiccated thyroid? I don't understand.
Right. Like, and really it is not understandable. I don't understand either, but there is a context. There's a, like, if I tell you like kind of how this all happened, maybe it would help with understanding why these providers are not checking everything. But it's interesting. Like the historical fact that really blows me away is that like this all started, thyroid treatment started with natural desiccated thyroid. I mean, like what? Like that's crazy. And that's because, in Chinese medicine, like 6th century, they didn't obviously have pharmaceutical agents. So they would ingest the thyroids of these animals and people would get better. So that's really interesting and it worked well. So like why did we stop doing that? And the reason, the historical reason for that is back in the 1950s, a pharmaceutical company developed T4 into a medication. And at the time, they had just discovered that the body takes T4, which is inactive thyroid hormone, and converts it to T3 active thyroid hormone. So they were like, oh my gosh, if NDT or T3 is not dosed correctly, it can actually hurt people. It can cause atrial fibrillation. It can cause people to be like super hyper. It's not as safe as an inactive form of the thyroid medicine. So if we know that the body takes it and converts it to T3 anyways, then like why would we not use this for everybody? Because it's a lot safer and the body will take it and convert it. And that's pretty much the thought process behind why that became part of the guidelines. Also, you have to follow the money. The pharmaceutical company that developed the first T4 basically infiltrated the American Thyroid Association by giving them millions of dollars in grant money and taking them out and blah, 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 blah. So it became part of their guidelines, and it became like, the standard of care. The interesting part is that even though these T4 medicines were FDA approved and they showed that they normalized TSH, there were no real clinical trials ever done. Like to this day, there are no clinical trials. So we know that T4 medicine normalizes TSH and it does help with symptoms, but it doesn't resolve symptoms in everybody and a majority of people, I think. But they never actually did a clinical trial to look at resolution of patient symptoms. There's never been a trial to look at how it normalizes T4, T3, reverse T3, and all of these concentration of other thyroid metabolites in the body. It was just grandfathered in. So that is what happened. And, the level of like indoctrination for primary care doctors and endocrinologists of you do T4 only, it's safer. If you put somebody on T3, they're going to have a stroke, they're going to die, and they can if it's not dosed correctly. Yes. But the problem is, most endocrinologists and primary care doctors have never been trained on how to properly dose T3 or NDT. And so they don't know what they're doing with that medicine. So if you come in on NDT and you ask your endocrinologist to dose titrate it, they're not going to know what to do. All they know to do is put you on T4. It's a lack of education. And it's also, you know, too much education for T4 only. Like, for example, you probably have done this, like going through school and everything, but in fellowship and in internal medicine residency, you take these like practice exams all the time, like in preparation for your board exams and everything. And this is so crazy. There's always a Hashimoto's question, or many, where it's like a female and she comes in and she's fatigued and she's gaining weight and she's has all these symptoms and her TSH is high and she has positive antibodies, but her T4 is still normal. They don't ever give you the T3 or anything. And so, the options are, put her on put her on levothyroxine, put her on T4, T3, don't do anything. And the answer is always either don't do anything or she's depressed, put her on an SSRI. I'm not kidding. Like that is always the answer. And so like ethically, I'm taking these tests and I'm like, oh my God, I know that's not the right answer, but like, do I want to pass the test or not? But it's really like, it's in all of the exams. And so like the indoctrination, the education for primary doctors and endocrinologists has been T4 only. It's been since the 1950s. It's been since it's introduced. It makes sense in theory that yes, you take an inactive thyroid hormone and your body should make T3 and you should be good and it's a lot safer. But it doesn't work in real life. And there have been no clinical trials to actually show that it resolves symptoms. There's actually data, and I can give you like some of the PubMed article, like kind of stuff to post if anybody is interested in that. But there is data like from New England Journal and from other places that T4 T3 combination therapy does improve symptoms for people. And I think it would be even stronger as far as like showing that it improves symptoms for people if the studies were done correctly. And we can get into that, but I don't think that the studies that have been done on this have been very good at all.
Yeah, it's been really, really interesting for me because I feel like I had to unlearn some of the things I learned in pharmacy school, and that's got to be. I feel like the longer you go to school and training, the harder it's going to be. I know one of the pharmacists I used to work with, who is in his 70s, he told me that a lot of his physician colleague friends actually were part of like when the whole like weight loss clinic scandals were happening with fen and amphetamines and so on and so forth. So the weight loss clinics would also put people on T3, people who did not have thyroid disease, right? And so a lot of them were seeing people going to the hospital because essentially the clinics, in an effort to get them to lose weight, they would induce an
Hyper.
overthyroid in them. And of course, you're going to have problems when you're giving a healthy person that does not need a medication, like high doses of medications, and combining them with amphetamines. So I feel like there's a lot, especially for the older generation of physicians, where they're seeing this and they're like, I'm just going to give this a hard pass, right? Because it's like, it doesn't feel safe. And the last thing I want to do is harm my patients, right?
Yeah, no, I mean, that's a big part of it, and I think too, like, over time, endocrinologists as, like, a unit have lost thyroid patients, like, educated thyroid patients do not stick with most endocrinologists, and that's because they don't do it right. I wouldn't either. But, they do sometimes seek out providers that haven't had training on how to dose this medicine, and it can hurt people if they're not dosed correctly. I mean, endocrinologists don't know how to dose it either. A lot of people don't. But if it's dosed correctly, people get better. They actually feel normal again. And that is like the point of why I left academia, eventually, and I started my own practice because I wanted to be able to do this correctly for people. And in an academic setting with other endocrinologists, again, you get the side eye. Like, this is not something we do. We just do T4. Like, what are you doing, you crazy person? So I wanted to do it right. And I wanted to also integrate like some of the functional medicine approaches to get the immune system to quiet down as well.
It's like a common question that I get and from people that do see their endocrinologists and they are disappointed, where I feel like endocrinologists a lot of times they really focus in on diabetes and all the different diabetes meds out there, which is so, so important. But at the same time, it's like with thyroid patients, and some will be like almost try to force them to prescribe the medications for them. But I'm always like, please don't be like their first patient on a medication, because like you want to work with somebody that is like really well trained in how to utilize the different thyroid hormones so that they can dose you properly, because absolutely medications can be dangerous if you don't use them properly, right?
And that's the reason why a lot of like the T4 T3 combination studies that are out there in literature, because you never get MDs to listen to you until you show them the study. You have to have your double blind placebo controlled trial that shows that there's improvement, but there's never going to be improvement until they do the study correctly. And not only is like it really important for you to get the right groups of people, because like there's hypothyroidism from having your thyroid removed. Then there's Hashimoto's hypothyroidism. Then there's Hashitoxicosis. Then there's Graves. There's so many different groups of people where they metabolize thyroid hormone differently, or they have like different needs for T4 and T3. There's so many variables, inflammation, if they're on prednisone, if they're on a beta blocker, like so many variables on how to group them together. You have to have the patients that are all the same, and then you have to have providers that know what they're doing with the medicine. If they're not dosing it right, of course you're not going to see improvement in patient outcomes and clinical symptoms because you're not dosing it right or you're giving them side effects. So that's a hard study to do. It has to be done so that people start to listen about what is the correct way to do this with thyroid replacement. And I'm hoping one day to be part of that. I would love that because there's only one way. It's really there's only one right way, but we have to do the study to show physicians that T4 T3 combination is really important. It's really important. Not for everybody. There are people that do fine on T4 only. But it needs to be dosed right and people need to start checking full panels so they understand how the medicine is being used by the body once it's in.
Yeah, absolutely. I hope that you do participate in some of those trials and make those studies happen. We do know that the studies clinical trials are incredibly expensive, and I think that's a rate limiting step for a lot of the smaller companies that maybe don't have as much, money to fund some of these, and I feel like a lot of times, thyroid patients, we do need to advocate for more research to be done for us so that we figure out how do we get this to be the standard of care? You talked about thyroidectomy versus Hashimoto's and how you metabolize and how you utilize thyroid hormones. Can we break that down a little bit? Because I know that some of the people listening probably have Hashimoto's, and there's others that are post thyroidectomy. And I don't think a lot of people are aware that, yes, both might be hypothyroid, but there's going to be some nuances to that.
Yeah, there are. I mean, so the first big nuance is if you've had your thyroid removed, you don't have any reserve left. You have no thyroid reserve. So you need full replacement dosing. And full replacement dosing, typically for most women, especially, you need both T4 and T3. You need combination therapy unless you are a muscle builder and you have really good like muscle mass because muscle is what takes the T4 and converts it to T3. That's where your deiodinase 2 is. And as women, we always have a higher fat mass. It gets worse through menopause. It gets worse with aging. You lose muscle mass and then have sarcopenia with the aging process. So fat has deiodinase 3. Deiodinase 3 is the enzyme that takes the T4 and makes reverse T3. And so it doesn't convert the T4 medicine well to T3. And so typically, women who've had a total thyroidectomy need both. And then if you have Hashimoto's, it just depends on number one, how destructive are your antibodies? So I did something on this before, but we always look at antibodies and we look at like the number on the page. The number on the page doesn't really mean anything in between people because you could have an antibody that's like really high on the lab scale, but it's a really weak antibody. It doesn't really do very much. It doesn't destroy thyroid tissue. It doesn't really do anything. Or you could have like a barely high antibody that's terrible and causes extreme symptoms. And by that, I mean your immune system is identifying your thyroid as not part of you and killing off thyroid follicular cells. And when those cells die, they release stored thyroid hormones. So you can have, if you put somebody on like a 24-hour monitor, like the blood sugar monitors that people wear, and you see like with your blood sugar swings throughout the day. Same thing happens when you have an autoimmune thyroid disease with very active antibodies. You get release of thyroid hormone during the destructive process, and that's worse with certain antibodies, TSI, TRABs, TG antibodies, thyroglobulin antibodies can be both stimulating and blocking. So TPOs are not as bad, but they can be. But like I said earlier, like everybody makes their own antibodies. Your body is making that against your thyroid. And if your body makes a really strong antibody against your thyroid, you're going to have a lot more symptoms. And then when you try to get on thyroid replacement, if you need thyroid medicine, it depends how much has been destroyed. So that's where, like, when I do a thyroid ultrasound, that's where that comes in because I can figure out, like, how long has this been going on for? How bad does the thyroid look? Like, what are we working with? Like, are we needing just a little bit of help or are we needing like a lot of help? And so the dosing changes depending on how much has been destroyed. Plus, when you go on thyroid medicine and you have the antibodies in the background, you're on the medicine and then your thyroid is like doing this in this and then not making thyroid hormone. And so you're kind of following a moving target sometimes with very active autoimmune thyroid disease. So those are the two main differences. Plus, people with autoimmune thyroid disease tend to have a lot more intolerance to excipients and fillers in their medicines. They have a lot of work to do with like their gut microbiome and other things that can help decrease inflammation in the body and repair their immune response. But like for a thyroid dosing standpoint, that's the main difference. And so there are some Hashimoto's, early Hashimoto's that don't need medicine. I have lots of them that we don't put on medicine, or just need T4 or just need T3 if they're not converting well. So, um, yeah, it's more of a heterogeneous population of patients with autoimmune disease.
Yeah, thank you so much for sharing that because it's like apples to oranges, right? It's like we have to make sure that we're on the right dosing protocol for ourselves, not for somebody else that might have a different antibodies, that might have different absorption. I know what I see a lot of people is they have trouble stabilizing on certain thyroid hormones, and there are certain excipients and fillers, sometimes in compounded medications, even in some of the more popular medications. And this could be they might have H. pylori, they might have gastritis,
Mhm.
they might have a coffee chugging with their thyroid medication problem, right? And so there's a lot of reasons why thyroid hormones might not be properly absorbed. And I think that's very, very common in people with Hashimoto's. Can you speak to that? And I know that's a very common question I get when people are like, my TSH is all over the place. Like, what is your approach for getting these people more stabilized?
Yeah, I mean, absorption is a problem. So when we're replacing thyroid hormone, the tools that we have in our toolbox right now are all oral pretty much. It's an oral medication, whether it's a tablet, a capsule, a liquid, whatever. But like, even if it's something that dissolves in the mouth, like you can compound troches and things, thyroid hormone is taken up by the small intestine, so it has to go down through the stomach acid. If you have H. pylori, for example, the pH of your stomach acid is too high, so you're not going to always break down the tablet like you need to get it open and to absorb 100%. Or gastritis, or people on chronic PPIs, people as they age don't make as much hydrochloric acid in their stomach, so there's all of that. And then once you get to the small intestine, the medicine has to be metabolized or broken down enough that you can actually absorb it through the small intestine. You have to not have celiac, that, or a malabsorption issue, because that can mess it up, like a past, surgery or something that can mess up absorption. And then SIBO, or small intestinal bacterial overgrowth syndrome, is something we see a lot of in the thyroid community. I just published a paper about that, and we found that 70% of people with hypothyroidism have SIBO. 70. It's a lot. It's a risk factor for SIBO, just like H. pylori is. And that's because thyroid hormone has such an impact on bowel motility, that, why you get constipated or diarrhea or just all over the place, IBS in general. And so 70% of people. And so if you have too much bacteria in the small intestine, not only is that really uncomfortable and you get like the 9 months pregnant bloating and you get indigestion and you get all these things, but also that bacteria can take your thyroid medicine and it can get rid of it. It can deconjugate it. It can undergo sulfonation and it can excrete it in the bowel instead of allowing you to absorb it. Or it could actually activate it and make you reabsorb it. If you have high beta glucuronidase in the GI tract, for example, from SIBO, that can have you reabsorb your medicine even more. And then you need a different dose, or your TSH is all over the place and your T4 is all over the place. So, bowel bacteria is another reason for why the TSH is so, it's a very important reason. It's like one of the most important reasons. And then TSH can be variable all over the place because of this autoimmune process going on in the background too, because the thyroid is contributing or not contributing. But primarily it's an absorption thing. It starts in the GI tract. And it's a struggle every day to try to get thyroid medicine in routinely and have people space their medicine and get them on the right formulation or chew their medicine to start the breakdown process. There's a lot of different tricks, but our tools are not the same as the normal thyroid. So we do our best with imperfect medicines, and then trying to get it into a small intestine that has bacterial overgrowth or other issues is also a secondary problem.
Oh, thank you so much. You explained that so well. And I feel like this just really highlights the importance of not just looking at the thyroid medications, but looking at the body as a whole, right? And so figuring out like, okay, do you have some gastritis or H. pylori going on? And how do we support the person as a whole individual to get them feeling their best? I know one thing that so many of my colleagues and friends and patients have missed over the years is like, not taking their calcium supplements or not having coffee within an hour of their thyroid meds, iron supplements within 2 hours, but there's so many different nuances that we need to think about. And when you take thyroid hormone, you do need to have that as a routine for yourself to make sure that you are utilizing it properly.
Yeah. Yeah. It starts with absorption. It really does. But then once it's absorbed, metabolism is really important. So there's so many variables that can affect that as well. Inflammation of any kind is a big one. And you do such a good job at like the root causes and like what's driving inflammation, and that could be a whole host of things that's causing inflammation in somebody's body, or it could just be too much fat tissue. It could be insulin resistance. There's so many things, so piecing together each individual patient is really important, and you can get well. You just have to have a provider that's thinking through all of that.
Yeah, yeah, absolutely. And I feel like some people go on for many years feeling terrible. And I've seen some people like try to take things into their own hands where they might order, I guess, glandular products from overseas or over the counter glandular products. What are your thoughts on that?
I mean, first of all, I understand. Like, this is like life altering. Like, it's terrible to be on the wrong dose of thyroid medicine. It is life altering. It has all of these bad metabolic consequences. So I get it. It's like a desperate kind of thing. Yeah, and I mean, there are providers that know what they're doing. So, and there's now telemedicine options. I have a whole telemedicine practice that I'm licensed in 9 different states now. So like even, people that aren't in my state can see me. But there are options for people that do know what they're doing with the dosing, and it's so much better if you can just find somebody that can be a partner in your care instead of just like willy-nilly taking whatever, because a lot of the stuff that you're sourcing maybe isn't, very well sourced. You could be getting like completely the wrong dose, or you could be getting a thyroid from a hypothyroid cow or a hyperthyroid cow. You could be getting cow thyroid or porcine thyroid that was fed GMO feed, or, you don't know what you're taking. And the dosing of this is so important. It's like the Goldilocks rule. It has to be perfect, or else you will not feel perfect. And it changes with time. So it changes during pregnancy, it changes during menopause. Menopause is a huge problem. It changes if you're inflamed, it changes as your weight changes. There are so many variables that go into how you metabolize these artificial medications, that just like sourcing something and taking it is not going to be the solution. But like I said, I understand because it is a life altering thing.
Yeah, I'm absolutely with you on that. I totally emphasize with people or empathize with people. Like I appreciate where they're coming from, but it just makes me really nervous because you don't really know how much thyroid hormone you're getting. Like the companies aren't actually allowed to like test and tell you how much is in it. So you could be overdosing yourself and underdosing yourself. And I've had some clients that, had purchased these products and they were still really, really struggling. And I'm like, there's a really easier way. Like, there are practitioners who know how to use all the different thyroid hormones. And now, with telemedicine being available, you can reach out to them even if they're like not right in your neighborhood. That's been one of the amazing things that have come out in the last few years where I don't want you guinea pigging yourself with that. Like, like it's just like really get like you need to be really precise with thyroid dosing because thyroid hormones are dosed in like micrograms.
It's like it has to be perfection. It has to be perfection. Yeah. And it's not a guess. Like so I know there's like a lot of endocrinologists or providers out there who they'll try NDT with patients and then it doesn't work. And then they'll try this and it doesn't. And it's just like a guessing game as to like what the dose is and what they should do. It all makes sense, and you just have to look at the panel and you have to talk to the patient. And I use all different forms of medicine. Some people do better on others, they metabolize it differently. So I use whatever I have in my toolbox to get everything perfect and to get results clinically so patients improve. And like I said, it's not, there's only one right way to do it.
I so appreciate you sharing that. It's just, I'm all about like taking charge of your own health, but like at a certain point, it's like, okay, let's let the practitioners do.
Or just help, like, piece it all together because it's complicated. Thyroid medicine is a complicated thing. It's not just it's a very complicated medical condition that got very dumbed down with TSH only and leave and T4 only. So, that's the problem, and that's kind of what we have to overcome as medical professionals to help people.
Can you tell us a little bit about your practice? Because I know that you don't just do medicine, you get the medicine right, but you also look into all of the integrative things as well. Can you tell us a little bit more about that and where people can find more about your work?
So, I'm down here in Charleston, South Carolina. I own the Charleston Thyroid Center. This is our going into our 6th year of practice, and we're super busy. We have patients from all over the US and international. It's hard to find thyroid care, but we have a telemedicine practice as well if you can't make it here. So the telemedicine is My Thyroid Doctor. And again, we're in 9 different states, but if you are in a state in which we're not licensed, you can go onto the website and request that. We look at that. It's spelled out mythyroiddoctor.com. Um, but yes, we look at the full picture. So we will look at the full panel of labs. We will assess, what you're coming in on as far as your thyroid medicine. A lot of like the kickback from like conventional endocrinologists about T3, checking a T3 is because they don't know what to do with that and it's so variable. But we always figure out like when did you last take your medicine and when is your lab being done because that's important. It peaks and troughs. So like knowing what you're looking at. We like to do a thyroid ultrasound as well because not only do we like to screen for thyroid cancers and nodules that you can't always feel that Hashimoto's patients are more at risk for, but it tells us the story. Like, how long has this process been going on for? Does this person really need thyroid medicine? We take about 10 to 20% of our patients off medicine. And then we look at underlying root causes of why they have an autoimmune disorder. And that includes everything from food intolerances to allergies, seasonal allergies. It includes gut microbiome work, a lot of gut microbiome work, because we talked about how important absorption is, but also that's a huge trigger to your immune system. If there's an overgrowth of bacteria or something there that's triggering an immune response, 70 to 80% of your immune system sits behind that gut wall. So that's a really important low hanging fruit. We look at toxic chemicals because all of that have immunosuppressive effects on the immune system and cause autoimmune disease. We live in a very, very dirty world, not only our food supply, but our water supply, our air supply, even the coffee, like it grows mold. Like there are so many things that activate the immune response. Hidden infections, we look at that too. Lyme disease, or I actually had somebody who had recently who had like vaginal issues ever since giving birth to her daughter and like discharge and things. And we looked at that and fixed it, and now she went into remission. So it's all of these things that drive the autoimmune response, and the autoimmune response is worsened with inflammation. So if you look at the underlying root cause of inflammation and you address that, we can get the antibodies to fall. So we get people in remission all the time. Depends on how bad the autoimmune process is. If it's been going on for a long time, it's a lot harder to get people in remission. So I don't always say you're always going to get in remission no matter what you do. And that's okay. That's not a failure. That just means your immune system was very active against your thyroid. But we work on that because that is looking at the full underlying cause for why this happened. It's an immune system problem. It's not a thyroid problem. The thyroid is an innocent bystander and it sometimes gets destroyed and you have to replace what's lost. But the immune system is the real problem. And that's what we really work hard on getting right.
Thank you so much for sharing that and for doing all the work that you're doing. And how fascinating with the woman who was postpartum, because we do know that so many women go have postpartum thyroiditis. And what if it is something in the vaginal microbiome? Do you recall what kind of an infection she had?
Yeah, it was, there was E. coli and there was Candida glabrata. And so I mean, that's a hard one to get rid of. But like just a simple treatment of that and you get into remission. I mean, that's amazing. And also, oral microbiome's a big one too. So I just learned this. I didn't even know this, but do you know that after root canals, they sometimes, like dentists and things, they look at the apex of the tooth on an x-ray and they see like a dark clearing at the apex of the tooth on x-ray that they just monitor, which is osteomyelitis. It's an infection after a root canal that just festers in the mouth forever. And they don't they're saying if you don't have symptoms, we just leave it alone. So like if you've ever had a root canal, that's another potential source of an underlying infection that of course your immune system is going to try to respond to. And so like those kinds of hidden things, we really work to try to understand each individual person and what's driving their immune response because it is possible to get in remission.
Yeah, it's so important. I just interviewed somebody who had thyroid cancer, and she ended up having infected root canals, and her wisdom teeth were infected as well. And she, with getting treating those infections, her thyroid, her tumors shrank, right? And so that was a big part of her healing journey. And it's just things we don't really connect from. I would have never thought about that in pharmacy school, that the wisdom teeth that, we all have pulled could one day contribute to a thyroid dysfunction, autoimmune condition, or cancer at some point. But these are such important things to consider.
Yeah.
You mentioned that about 10 to 20% of the patients that you see can get off of meds. And I'm curious what kind of a workup you do with them and how that process looks, if there are some commonalities. I know with postpartum thyroiditis, or if somebody is a teenager, they're more likely to just need a short term thyroid therapy. Are there other types of patterns that you see?
Yeah. So there are three things I tell people in order to, well, maybe four, that you need in place in order to get off thyroid medicine. So the first is you have to have enough viable tissue left that looks okay on ultrasound to try that. Because there's a lot of stuff out there that, like, oh, nobody really needs medicine. Like, just stop your medicine. Don't do that. Please don't do that. Because then we really get all messed up. And you have to know that it's healthy enough to fly. It has to be able to start again and do what it's supposed to do. And then number two, you have to have antibodies down as much as you can, because if you have an autoimmune process that's continuing to go on, your thyroid is being stopped from making thyroid hormone by those antibodies. So it's not going to be as easy of a journey to get off medicine if you still have really high antibodies. Do I have people that have gotten off thyroid medicine with high antibodies? Yes, but typically those antibodies are not very destructive. They're not very strong. And when I look, it looks like they're not really doing very much. So, whatever, those people can come off. And then inflammation has to be at an all time low, because if inflammation's not low, even if your thyroid kicks back in and starts making the thyroid hormone that it's supposed to make, again, a majority of the thyroid hormone it makes is T4. So then your body has to take that and convert it to T3 active thyroid hormone for you to feel good and for your TSH to normalize. It's not going to do that if you're super inflamed, or if you're on prednisone all the time, or if you have asthma and you're on an inhaler that has steroids. Like, all of that kind of stuff really has to be taken into account when you're thinking about coming off medication. And then I also tell people, like, if you can get your weight down to a normal weight, that's so helpful, because thyroid hormone is weight dependent. And that's why, like, as you gain weight, you start to see more hypothyroidism or TSH coming up. But if your weight comes down, it really does help the thyroid to work optimally. And even if you're working with a gland that's only 80% functioning, that's enough. If your weight is down, that's enough. So those things need to be in place typically for it to go well.
Thank you so much for sharing that, because if we have enough thyroid tissue, then the thyroid gland can still compensate for us. And if we have some of these root causes and triggers addressed that aren't constantly driving the autoimmunity and the ongoing destruction, then I feel like there's some hope for coming to an equilibrium.
Absolutely. I like my hope would be that people would find Hashimoto's earlier before it destroys the thyroid, that we would work on these underlying root causes of inflammation and look at gut microbiome and look at sensitivities and get on, anti-inflammatory supplements and all of the good things that are so important in fixing the underlying problem, but finding it early and some people are lucky. I had one patient recently who had been on thyroid medicine for 35 years and she came off fine. But, that's not always the thing, but it's possible. And it just really depends on the situation. But if you find it earlier and you fix the underlying root cause of the inflammation and the autoimmunity, you have a much better chance of not needing medicine or coming off medicine.
Yeah, I love that. I'm a big proponent of like everybody should have their thyroid antibodies tested. Now, as far as inflammation, do you look at specific markers for that, or are you just looking at a person's overall health and well being?
I do look at some inflammation markers. ESR/CRP, in my opinion, is not a very good one. Sometimes they're high, but not very often. So, like ferritin is a really good one as an acute phase reactant. We check ferritin all the time for iron deficiency, but it can be elevated in inflammation states of inflammation, and it's very commonly elevated, honestly. And I also find that it's elevated in things like fatty liver disease and in toxic chemical exposures and things. We also look sometimes at cytokine panels. So we'll look at TNF alpha. TNF alpha it stands for tumor necrosis factor alpha, and it sounds terrible, but it just means inflammation. And then all those other cytokines, those are signals from your immune system in your bloodstream as to like what is going on. Is it an infection? Is it allergies? Is it insulin resistance? It really does help to try to kind of narrow down where you're looking. Um, and yeah, I mean that's the main kind of thing. And then just talking to the patient, the patient is going to tell you they have migraine headaches or joint pain or fluid retention, like all of those kinds, sinusitis. But all of those clinical symptoms are really important clues to inflammation and really working as to like what is causing that. And there's always a cause. And if you figure that out and fix it, then the inflammation goes away and the patient gets better.
I love that. There's a lot of detective work to be done, and I feel like most practitioners don't do the detective work, and I so appreciate you doing that. I know I came across a study with blastocystis hominis, which was one of the things that was triggering the autoimmune inflammation in my system, and how that has an impact on cytokines. And it's kind of like when you start peeling back the layers and you start thinking about like, well, why is this out of balance, right? And what's causing it to get out of balance? You can really find some answers and really tame that inflammation instead of just being like, here, take some NSAIDs, or here, take some steroids, which of course have their own set of side effects.
Yeah, it's all about like self love, like realizing your body doesn't hate you. It's not trying to attack you. It probably is doing that because it's either confused by a chemical exposure, you have an underlying infection that it's trying to fight off. Like it's doing that on purpose. There's a reason. So, like, if you figure out the reason, your immune system will go back to normal.
I love that. I've seen that in my experience as well. It's just remarkable to see so many different root causes and drivers. It's amazing. I feel like I learn about a new one every month, every other month. It's like, breast implant illness for some people that might be a really powerful trigger. For other people, it's H. pylori, and there's just a lot of different things that can really mess up our immune system. And when what I really appreciate about functional medicine and some of the integrative medicine is like we actually try to figure that out.
That's key, and it really shouldn't be functional medicine versus conventional medicine. Like, I don't think anybody should say, I'm only doing conventional medicine. I'm not doing any functional, and vice versa. People shouldn't say, I'm not taking any like sometimes medicines do help, but like if you can marry the two and like proper medical care is doing both well and figuring out the root cause, like that is key so that people can come off their medications, and they can not go to the doctor anymore. That's the point of medicine.
Thank you so much for sharing that. I'm going to ask you some rapid fire questions, but before I do that, I was hoping you could tell us a little bit more about your book. I think you already gave us your website, mythyroiddoctor.com, and where people can get more information on you.
Yeah, so you can read more about the thyroid. I wrote a book called What You Must Know About Hashimoto's, and it's bridging both conventional and complementary medicine for thyroid healing. It's on Amazon, it's on my website. You can always come visit in Charleston, South Carolina. It's a beautiful place. So, charleston or if you're in one of the states in which we're licensed, which is Minnesota, Ohio, Arizona, Virginia, Tennessee, North Carolina, South Carolina, Georgia, and Florida right now. We can see you virtually and you don't need to come in person. So that's mythyroiddoctor.com. You can always follow me on Instagram. We try to put out content all the time to help people to understand, their thyroid. It's a complicated thing or to ask questions. That's Dr. Henderson, MD. Um, and yeah, I that's where you can find me.
Now I'm going to put you a little bit on the spot and ask you some rapid fire questions.
Okay.
Maybe they are not in your repertoire, but is there a wellness hack that you refuse to participate in?
I don't do the whole like castor oil on my thyroid thing, but I would use it for hair loss because it does help with inflammation.
Perfect. Thank you so much for sharing that. If the supplement police were to come to your house and say you have to give up all of your supplements, but we'll let you keep one, what would be the one that you would keep?
I would probably have to say I like I like the cortisol reducing ones because I have a very stressful life. So I like to sleep and I like to not wake up at 2 in the morning. So like any of the cortisol managers or cortisol calm or cortisol reducers are my favorites.
Thank you so much for sharing that. That can be a huge game changer for people with adrenal issues and insomnia that is driven by adrenal issues. Um, One last question. Are there any health myths that you would like to bust?
Um, I would like to, I said one of them, like the high iodine thing. I don't love that all the time. Like, I think people should think through that a little bit. I don't think everybody can come off thyroid medicine. Unfortunately, I hope that one day we as providers start screening people earlier so that they don't need this because it's terrible. But, think through that before you come off medicine. And then also, like for thyroid cancer, that's a hard one, like for integrative medicine. Like I do see people that are trying to just do a functional medicine approach for that. And I wish people would marry the two, for thyroid cancer because cancer is it can shrink like your person it can shrink when the immune system is healthier and can suppress cancer growth, but it doesn't go away typically. So like to be able to use both conventional and functional medicine approaches for cancer and to increase natural killer cells and use mushroom extracts. All of that's awesome. But like, just think through that a little bit too.
And thank you so much for sharing that. And I totally agree with you with an integrative approach. And the guest I had did use an integrative approach of utilizing surgery and utilizing the integrative therapies as well.
Yeah, love it. Love that. And that's so important. Like, I always tell people, like, you have to support your immune system in cancer. You have to. It's so important to prevent recurrence. So, yeah.
Best of both worlds. And I really appreciate the work that you're doing in combining conventional medicine with integrative and functional medicine to truly serve thyroid patients. I want to thank you for the time that you've given us. And for everybody listening, I hope this has been a healing part of your journey.